going to include 4 presenters that will be introduced by Prof Mentjies after a very short study update by one of the co-PIs, Dr. Shaun Wasserman. So in the sake of time, I'm going to ask Shaun to start, and then thereafter, Graham will take over and do the introduction.
Thanks, Elsa. Hi, everyone. Welcome to this webinar again from my side. My name is Shaun Wasserman, one of the principal investigators of the REVIVE trial. As is customary, we're going to start this webinar with an update about progress on REVIVE. And before I give you an update, I just want to tell you, for those people that aren't familiar with the REVIVE trial, what it's about. So this trial is testing an intervention among people with advanced HIV disease who have a very high early mortality, even though they are starting or restarting on antiretrovirals. And one of the hypotheses for the cause of their early mortality is undetected severe bacterial infection. And so the REVIVE trial sets out to test whether an intervention of azithromycin prophylaxis can reduce mortality in this population. It's a pragmatic trial, so it's been delivered within mainly routine care across multiple sites in multiple countries. It's double-blinded and placebo-controlled, and it's an event-driven trial with mortality as the primary outcome at 24 weeks. We're including people who are adults who have CD4 counts less than 100 and are relatively stable, not on active antibiotic therapy, and they are getting randomized to receive azithromycin 250 milligrams daily or placebo for 4 weeks, and then followed up for the primary outcome at 24 weeks and for a secondary outcome at a year after entering the trial. Very importantly, the azithromycin or the placebo, the trial intervention is given on top of whatever regular care they would receive, and hopefully that's all care that is evidence-based for advanced HIV disease. And we hypothesize that the azithromycin will reduce mortality in this population compared to placebo. Next slide, please. And so we're doing very well, and we have lots of partners, many of whom I think are on the call today, including one of the speakers, Kemi from Nigeria. I'm very proud and excited to tell you that there are 11 countries that are actively recruiting to the REVIVE trial. You can see them in green on the map here. And we have 2 additional partner countries that are going to come online very soon. We're very excited to welcome them, Cameroon and Kenya. And there are a total of 46 activated sites across these 11 countries, which is fantastic. Next slide. Over 3,000 participants, 3,200 participants have been randomized into the trial over about 2 years, which is incredible. And the investigators are randomizing more than 200 participants every 30 days into the trial. In that colored column there, you can see the numbers that are potentially lost to follow-up, very, very low, and data completion is almost 100%. You can see that every single country is making an excellent contribution, and I'm very excited that our latest partner country, Ethiopia, is randomizing actively. It's great to see, but everyone's making an amazing contribution, so thank you. Next slide. This is the overall recruitment progress. The blue line is the expected recruitment, so what we are aiming for, and the purple line is the actual recruitment running every month. And you can see that the purple line is just above the blue line, which is very healthy and means we're actually going faster than what we project, and we'll hopefully finish this trial early and get an answer to this very important question earlier than anticipated. The anticipated end date is November 2027, but we think we'll get an answer before then. Next slide. And the final thing that I want to say is just to tell people about a very important event in the life of the REVIVE trial, which is the launch of, finally, the launch of our website, which is going to go live on the 1st of September, so next week. And all you have to do is go into Google and type in REVIVE trial, and you will see a link to this website. And it's a beautiful website. You can see the front page here, and we really encourage everyone to engage with it and to share it with your networks. So Elsa, thanks very much. Thank you again to the speakers, and looking forward to this webinar.
Thanks very much for the update, Shaun. I'm Graham Mentjies, the chair of the Trial Steering Committee, and I'd like to welcome everyone. Thank you for attending this webinar today. It's great to see such a good turnout. Just to provide some context at the start, I think most people work in the HIV field and will be aware that antiretroviral therapy has evolved dramatically over the last 2 decades, with the medications that we use having fewer side effects, being less prone to resistance, and easier to take in fixed dose combinations. And evidence-based guidelines have moved to supporting the approach for patients to start treatment as soon as they're diagnosed with HIV. And we now know from epidemiological studies that if a person living with HIV is started on antiretroviral therapy, they can live a near normal life in terms of life expectancy and quality of life. But what has remained a persistent challenge is adherence and retention for our health services and for people living with HIV. And that has the impact that we're not fully able to realize the full public health benefit of antiretroviral therapy when people still have the challenges around adherence and retention. And that's the focus of the webinar today. We've got 4 speakers. The first 2 speakers will really provide an overview of these issues around adherence and retention. And then the third and fourth speaker will focus on challenges and experiences in 2 of the countries in which the REVIVE trial is being conducted. And that will be followed by a question and answer session with a panel discussion with all of the speakers participating. So our first speaker is Lynne Wilkinson. Lynne is a technical consultant with the International AIDS Society and a research associate at the University of Cape Town. And Lynne will be addressing the issue around barriers and enablers for retention in ART care. So welcome, Lynne, and thanks very much for participating. If you're able to share your slides.
Yeah, let me try that. Yes, so you can see them.
Yeah, that's coming up fine. Great, thanks.
Okay, perfect. Just give me a second. Okay, so good afternoon, colleagues. I'm going to take you through the barriers to re-engagement experienced by our ART clients who have missed their scheduled appointments, prolonging their treatment interruptions unnecessarily. So we all understand the treatment pathway to be cyclical, with people living with HIV disengaging and re-engaging with a cascade at multiple points in their treatment journey. This example from the entire HIV cohort in the Western Cape, South Africa, shows in the orange block how common treatment interruptions are, but equally how many people are re-engaging back into care in the blue block. These studies from Malawi and South Africa show that the majority of people who have missed scheduled appointments for treatment collection actually return to us within 3 months. On the left, you'll see a study of the entire Malawian cohort that shows that approximately 60% of all ART clients experienced an interruption, but that the vast majority returned within 100 days. And on the right, in South Africa, this is made up of a number of selected facilities in Johannesburg that reported almost 2/3 of their clients who missed appointments returning within 2 weeks. And of those who returned after 2 weeks, less than 1/3 were out of care for more than 3 months. So to understand re-engagement better, I'm going to go through each piece of the puzzle, and this really comes from this diagram comes from a qualitative study in Malawi. But it's briefly important to understand that people who disengage have specific vulnerabilities, increasing their risk to disengagement. But actually, these clients then experience a specific proximal event, commonly unplanned need to travel, that results in a missed schedule appointment. We then commonly, as the health system, look at facilitators to re-engagement with quite a big focus on tracing and recall. And while the Malawian study identified these as important, they actually identified stronger facilitators outside of the health system. So our clients' strong dedication to ART, their internal motivation not to become sick, as well as their social support from both family and their financial means that drive that decision to re-engage. And this really means that we need to focus on the barriers that clients experience despite their intention to re-engage fairly quickly and thereby prolonging their treatment interruption. So we can really therefore summarize the reasons for engagement amounting to a client's personal motivation to re-engage, removing the barriers to achieving this intended re-engagement, and considering how we can enhance the facilitators to increase that support. And I'm now going to dive into the literature to better understand each of these components. Both the South African and Malawian qualitative studies strongly show how clients have this personal motivation to return. And this was further found in a Zambian multi-stage sampling-based study that looked at reasons for return, with the most common reason being people's personal motivation, despite knowing the barriers, with very few people reporting only returning once they were sick. So providing more detail on barriers respondents reported, these were often limited clinic hours when you wanted to return, inflexible appointment schedules, constraining their ability to return, and when they were returned, often being turned away to come back at a different day or requiring different documentation. We also know that clients' perception of healthcare workers' response at return after a missed scheduled visit can impact their decision on how quickly to return, thereby delaying their return. We see these barriers experienced through South Africa's community-led monitoring data from Richidze, which interviews clients when they leave health facilities, not only those returning late. And in this, you'll see that 688 in the last survey reported healthcare worker judgment of people when they did miss their scheduled appointments. 50 people reported being refused art on their day of return, and only 4% offered easier ways to collect treatment once they did return. Here I'm highlighting a 2024 HD study from hospitalized patients in South Africa that showed that prolonged interruptions until people were sick and therefore hospitalized were often as a result of not being able to transfer to a new facility and that fear of the healthcare workers' response after a brief interruption. So now moving to the facilitators, and really here highlighting the role of family and social circle support to return, the financial means to return, and not underestimating community health worker outreach in encouraging that return. The same Zambian study, which I referred to earlier, found that people would be motivated to return if health system barriers reduced their waiting time at late return, the quality of care when they actually did returning, including respectful care and easier ongoing art care. The reasons for silently transferring to a new facility are also illuminating and reflect the same motivations. People silently transfer due to reduced time having to be spent at a new clinic, more respectful and quality care, and avoiding the fear of returning to a previous clinic after missing an appointment at that clinic. So reducing prolonged disengagement, ensuring easy, quick, and durable returns will reduce the need, costs involved in tracing, hospitalization, morbidity, mortality, and obviously onward transmission. In summary, we can rely on our clients' personal motivation to return after a missed scheduled appointment, but it is our role to reduce the risk of a prolonged interruption by prioritizing respectful care for people returning and those observing others returning, reducing waiting times on the day of return, completing the re-engagement on the return date, same-day art provision, avoiding multiple visits and transfer documentation collection, increasing appointment schedule flexibility when missing a visit and after return, not intensifying appointment schedules after return unless clinically necessary, and accelerating as far as possible access to multi-month dispensing, so longer refills and less intensive differentiated service delivery models at return. The good news Oh dear, I've got some animations I didn't mean to have. The good news is that ministries of health are starting to implement guidance on managing people returning to care, focusing on respectful care and shifting away from a one-size-fits-all intensified clinical management with monthly appointments and multiple adherence counselling sessions. Differentiating care pathways by identifying patients that are merely late for their scheduled visit with no or brief treatment interruption and who can continue their routine care, including their DSD models. And then, again, another one. And then for those that are classified as re-engaging, differentiating service delivery at return based on these two key assessments. First, clinical stability, assessed through signs of opportunistic infections, mental health conditions, advanced HIV disease, or an elevated viral load prior to disengagement. And secondly, the time since missed appointment, which indicates the potential interruption duration and advanced HIV disease risk. South Africa and Zimbabwe, and recently Eswatini, have formalized differentiated re-engagement pathways in their national guidelines, which allows people to get longer refills and earlier access to DSD based on clinical stability and time to missed appointments. I don't have time to go into these, but I have shared them at the end of my slide deck, these algorithms, if you're interested. And I've also just shared here for you some additional resources on re-engagement from the WHO and from IAS. Thanks very much.
Thanks so much, Lynne. That was a fantastic high-level overview of the issues and picking up on what health systems can do and are doing to facilitate return to care after a disengagement. So we won't take questions at this stage. We're going to move on to Catherine. And Catherine Orrell is an HIV clinician, clinical pharmacologist, and a director of HIV and other infectious diseases, the research unit at the South African Medical Research Council, also a researcher at the Desmond Tutu HIV Centre and professor at the University of Cape Town. And Catherine's going to be addressing issues around ART adherence and retention, including some of the research that she's led over many years. So over to you, Catherine. Thanks very much.
Thanks, Graham, and thanks, Sean, as well, and also for the invitation to speak. I'm going to stick, I think, more to adherence because Lynne has so kindly, has also gone through the retention piece already. So just the sort of measure of adherence for me is viral suppression. When we look at our 90-90-90, we don't quite get to our 90%. Children are worse off than adults, but we're sitting sort of in the 85%, 83% of people being virologically suppressed. And what concerns me, again, speaks to what Lynne has been talking about, is that I'm not sure the denominator is correct. What we really want to see as success is viral suppression of the numbers of people that have started, not the numbers of people that have a viral load drawn in the clinic. And that then speaks to the retention piece, that those people that are missing between those who started treatment and those who are actually coming for viral load. So I'm going to whip past the next slide, which, because there's increased recognition that retention in care is as important as adherence. And just to quickly show you some data from Claire Keane, who people might know, who has worked in the Western Cape for a long time, showing patterns of engagement over 1 year from initiating ARVs, and that only 58% of people have optimal retention. But as Lynne said, a lot of people who leave do come back, but there are a certain group of people who don't come back. And we find that people who disengage, although they're likely to engage again, only 29% of those people that re-engage have a suppressed load a year after restarting ARTs. Have to look at their adherence when they are back in care. So for me, this slide just speaks to how important it is to achieve viral suppression, both for individual health, the reduction in U equals U, the reduction in transmission, but also because people who are virologically suppressed do not transmit HIV, and those at risk, it's viremic people who actually drive our epidemic. And so it's behoving on all of us as healthcare workers to try and keep people in care and to keep them virally suppressed. However, when it comes to measuring adherence, here we are 30 years into this epidemic or more, and we actually don't have a gold standard for measuring adherence. I was involved in a guideline in 2012 where we sort of looked at various forms of adherence, but even sort of 10 years later in the 2022 Cochrane review, there's no gold standard for measuring adherence, and most adherence measures that we use do not actually predict virological outcomes. So what have we been using? We've been using self-report, which for me is an excellent clinical metric. It doesn't predict virological outcomes, but as a clinician, it's a very important question to ask. It's like, how do you feel you're doing with your tablet taking? Can I help you with your tablet taking? Are there any times when you miss doses? Sort of open-ended, non-judgmental questions that might allow a better connection with a person and allow them to say to you that they're struggling with their dosing. But if you actually had to ask people to tell you how many tablets they'd missed, they will say, no, I haven't missed any, doctor, and you get a sort of median of 100%. So self-report is not a good metric for measuring or predicting outcomes, but a good clinical tool for engaging with people to try and improve their adherence. We've used tablet returns in the past in the Guguletu Community Health Centre. It's quite cumbersome. People bring their tablet bottles back. You could count how many tablets remain. You need to know, though, when they got that tablet bottle and how many tablets they were given at the time. And there could also be tablets at home that mess up the calculations. So generally not recommended. What is recommended as a more objective measure of measuring adherence is having a look at pharmacy refill data. And this is an objective measure that when our treatment guidelines say, we should be assessing adherence objectively, this is something that we all have access to in our clinics. And that is how many prescriptions have people filled in the last 12 months. And you can have a look and see if people have come 8 times to collect drug or if they've come 11 or 12 times to collect drug. And it's fairly easy to actually assess and does have some predictive value when it comes to virological outcomes. The more sort of research-based measures like electronic monitoring we have shown at our site, we've shown that using an electronic pillbox predicts virological outcomes, but obviously these pillboxes are expensive and you need an extra person to sort of manage all the pillboxes. By the time you have 500, 600 people using an electronic pillbox and you need a report, then that requires extra staff. So for now, I think electronic monitoring is probably more of a research tool. But what is up and coming and exciting are drug concentrations. And I'll just speak to those a little bit more. We used electronic monitoring for a TB study called TB-Mate. And if you can see my pointer, but the little graph in the middle there, you can see that people who had the adherence support, their adherence was a lot higher than the people who did not have the adherence support in this cluster randomized study. And in terms of drug concentrations, we've been using, there's a new urine tenofovir rapid assay. It's down the bottom on the left there. It's like a pregnancy test. And that tenofovir rapid assay basically shows if you've got tenofovir in your urine, which reflects the last 2 to 3 day of doses, and could easily be used in someone with viremia to see if they're actually taking drugs and whether or not you should be supporting adherence or exploring resistance in those people. There's also a tenofovir diphosphate assay where you look at tenofovir diphosphate and dried blood spots. Tenofovir diphosphate is a long half-life breakdown product of tenofovir. It sits in the body with a half-life of 17 days. So your tenofovir diphosphate concentration reflects how much tenofovir you have taken over the last 4 to 8 weeks. So it's more like an HbA1c for diabetes. It gives you an idea of dosing over the last 2 months. Not as susceptible as the urine tenofovir rapid assay to white coat dosing, where people know they're coming to clinic and they're like, oh, better I take my tablets. And you find some people, their urine will come up as positive for tenofovir when they've actually only dosed for 2 to 3 days, whereas the tenofovir diphosphate will still show a very low concentration in the blood because they haven't dosed that well over the last 4 to 6 weeks. So some of our work has actually shown that the tenofovir diphosphate is not only predictive, it doesn't only show low tenofovir when the viral load is raised, but it actually shows that low levels of tenofovir diphosphate 2 months prior to failure is actually predictive. So a tenofovir diphosphate concentration of less than 400 femtomoles is predictive of failure 2 months in advance. So although this is a research tool, I have been doing some work with a bioengineer at the University of Washington who are hoping to be able to make this into a point of care tool. So rather than being something that you draw blood and you send off to the lab and it takes 3 weeks to get back, so you've actually only got 1 month of that prediction. If we could do it in a rapid assay at the bedside, then with tenofovir diphosphate, we would have a sort of step up on getting ahead in terms of encouraging people to take tablets, because prior to the time that they reach failure. So in my last couple of minutes, just like when we talk about how do we impact on poor adherence, one of the points I wanted to make is that we don't lose people in clinical trials, and you can see that as the REVIVE study. But you can see from general data is that we do lose people in our standard of care, and so it behooves us to think of like, why is that? And I feel it's the connection that we get. And when we look at how we impact on poor adherence, it is cognitive behavioral therapy and treatment support and connection through a supporter plus a telephone that actually might improve adherence. Often, if you're looking at particular adherence interventions, there's a lot of things that don't improve things for long, but everything that does work seems to be linked to communication and support. Just a recent review we've done, the last few things, and it kind of nicely comes back to talking about what Lynne has been talking about. What we've seen in this review, where we've done of 234 recent studies, is that we do get some improvements with counseling, we do get some improvement with the use of peers, but the things that really do improve connection and adherence are actually task shifting of delivery or counseling of care, and changing in schedules for dispensing of ARVs. So it's making things easier for people, making it easier for them to access care. Then people can come, have tablets in hand, and then they can take their treatment. So our epidemic is driven by those not in care and those struggling with daily doses. And I think our need is to simplify. And I simplify it down to, if people struggle with keeping visits, let's reduce visit frequency, make it easier for them. If people are struggling with daily dosing, remove daily dosing, which takes my other topic of interest at the moment is long-acting injectables, the fact that we don't have access to long-acting injectables for people who remove daily dosing. And I'll stop there because I think the rest was just a summary and that's it. Thank you.
Thanks so much, Catherine. Excellent overview of many of the issues relating to ART adherence. As I said, we won't take questions now. We'll keep that till all 4 talks are complete. We're going to move on to our 3rd and 4th talk, which really reflect on these issues at a country level. And our next speaker is Kemi Adekanmbi. Kemi is a physician and infectious diseases specialist, senior lecturer at the University of Ibadan in Nigeria, and acting director of the Infectious Disease Institute there. Kemi is also the principal investigator in Nigeria for the REVIVE trial, and oversees 11 trial sites in Nigeria. And really looking forward to hearing the perspective on these issues from Nigeria. Over to you, Kemi.
Thank you, Graham, and hello to everyone. And thank you for the invitation to share the Nigerian experience. There were 2 million people living with HIV in Nigeria in 2024. 87% of them were on ART, and 90% of the 87% had achieved virologic suppression. In assessing ART in our clinics, it's often calculated by assessing a match between the scheduled and the actual drug pickup dates, so pharmacy review, and there's also self-reported adherence. And of course, virologic suppression rates are a good surrogate for adherence, but not done frequently enough. We're getting them done only once a year for most of our patients, and of course, may underestimate adherence in instances of drug resistance. So what challenges do our patients face? I believe that the strongest group of challenges they face are socioeconomic factors. So Nigeria has had a bit of an economic downturn in the past few years. The economy looks good on paper when you read the news, but in everyday lives, people are having a hard time meeting their basic expenses. So feeding, housing, transportation, and when that happens, any form of healthcare costs tend to take a back seat. And of course, there's lack of support. If people are struggling financially, even friends and family are not able to help because they tend to be in the same kind of financial situation. And then there are issues around insecurity. There's been some insecurity in Nigeria, and that has an impact on people's ability to engage in commerce, make money, travel, and do the things that they need to do to get to come to clinic to collect their drugs. There are widespread religious and cultural beliefs around divine healing, and sometimes that is to the exclusion of Western medicine. So people will believe that they were healed at church or wherever else they have their religious congregations, and they believe that if you believe you're healed, then you should stop your medications, and it's sometimes difficult to get around that. And of course, comorbid illnesses, including mental health illnesses, are a big problem. When people are sick, sometimes they don't take their medication. Sometimes they're not able to take their medicines. They're not able to come to the clinic. And this impacts their adherence significantly. And there's also a poor understanding of the importance of long-term adherence, even though people are counseled before beginning medication and also throughout the course of their care. And there's also drug fatigue and a high pill burden. People who have taken medications for a long time sometimes just decide they don't want to do this anymore. And then poor planning, forgetfulness. Some people will keep their medications at their places of work because they haven't disclosed to their families. They don't want people at home to know that they have HIV. And then they forget to bring medications home over the weekend. So this kind of problems can lead to adherence issues. And then for children and adolescents, sometimes some of the children are orphaned and they don't have anyone necessarily advocating for them to take their medications. Some of the adolescents go through a period of rebellion. And so all of this again ends up with resulting in low adherence rates. And on the program side, there are major health workforce constraints. And so counselors, nurses, doctors are not able to spend as much time with patients as we would like. There are funding constraints. In our program, there's no financial support for patients for food or for transportation to the clinic. There are high out-of-pocket payments for comorbid illnesses. So there's no universal health care available for most patients. And they have to pay for illnesses, and sometimes HIV gets pushed to the back. And then there's inadequate mental health support. As far as I know, most of our clinics don't have mental health facilities domiciled in the clinics. So they have to get referrals, and it takes a long time to be seen by a mental health specialist. And of course, there's still stigma. And sometimes this stigma comes from we, the healthcare workers. Retention, as we know, generally means people who are active and in care. And the metric in our Nigerian programs that we look at is interruption in treatment, which is being 28 days or more late for a scheduled drug pickup or clinic visit. We previously focused on the loss to follow-up definition of 90 days or more, being 90 days or more late for a drug appointment or for a pickup appointment or clinic visit. But we now focus on the IIT. Of course, the IIT definition enables more aggressive follow-up and tracking, but it also gives an exaggerated picture of loss to follow-up because many of these patients do come back into care, but it allows us to detect people who might not earlier in the picture rather than waiting 90 days. So a lot of the factors that affect retention affect adherence. We know it's impossible to be adherent if you're not retained in care. And so the same issues of non-disclosure, social support, lack of motivation, the financial and time cost for transportation. We have, I think, a substantial number of patients who receive medications far away from their communities because they don't want to be recognized. And so it takes a long time to get to the clinic. They spend a lot of time at the clinic and a long time to get back home. And the distance that they have to cover means that they have to spend more money. And so the time and financial cost is more than many people are able to bear. And then there's the issues of the mobility of our relatively young population. A lot of people travel for work, for commerce, and they plan to travel for a month, but they end up being away for three months. They run out of medications, and then they run out of medications, they don't come back to clinic. And some of them feel like, if I've been well for the past 3 months and I wasn't taking any drugs, maybe I don't need to go back to the clinic. And then in general, we don't have a central database that is able to tell us when one person leaves a program and transfers into another program without a referral. So those people might still be in care, but elsewhere, but they might register at our facility or at the initial facility as lost to follow-up. So this is the adherence and the adherence at our Revive sites. So for adherence, I'm using virologic suppression because these were the numbers that we could readily get. We have 11 sites in Nigeria. They are all affiliated with tertiary hospitals. So, and they're all teaching facilities. So research is going on. And so the adherence that you have here might be higher than what you have in other programs or across the country in general. The clinics vary from relatively small clinics of about 1,000 patients to over 7,000 patients. And we see that with the exception of 203 and 211, we have adherence rates of 90% and above. We have just the one site that is above 95, that's 95% or above. And I understand from the PI of 203 that they're having some management and other issues at this time, which are being addressed. But this time last year, their virologic suppression rate was actually 91%. And then in the last column, we have the IIT rates, which again are very, they're very unstable. They go up and down based on what's happening at that particular point in time. And this is just showing the map of the country. These are the states that contain the Revive sites. We have sites in all but one of the 6 geopolitical zones in the country. And so we hope that whatever comes out of Nigeria for the Revive trial is relatively representative. And these are IIT numbers, but you've seen this in the table already. So I'm looking at this. The reason I pulled this up is because it's a review that was published last year that looked at retention across 54 studies conducted between 2005 and 2021, and the pooled retention rate was 72%. So if you contrast this with our sites, where they're all tertiary facilities, there's a bit of social support, there are trials like the Revive trial going on, where there's generally more support than perhaps the community-based programs. You see that we have higher than normal. If you're trying to look at the entire Nigerian program, you'll see that what we have is more, our rates in most Revive sites is higher than the general other sites in the country. And what they found in that study was that there was significant regional variation, and then patients who were in programs that are linked to tertiary hospitals, patients who are seen at urban centers or private facilities had better retention rates, and women also had better retention rates than men, children, and adolescents. They also found that key populations had lower retention rates. So what has worked for adherence and retention? So enhanced adherence counseling. So pretty much what Catherine and Lynne have said, enhanced adherence counseling, communication, intensive case management follow-up, which I must say has suffered some since the US funding cuts have come. Extended clinic hours, which is practiced in some of our clinics. I know in Lagos, they have weekend hours, particularly for students and people who are able to get away from work, who are unable to get away from work during the week. Various differentiated service delivery models, funded peer support programs. There are youth clubs and youth programs where they have youth peers who use coded messages via text to remind people to take their medications. So they might get a message like it's time, it's showtime, or it's time to pray, or something like that. And so even if somebody else sees that message, they don't realize that the patient has HIV. And a lot of these are funded by external partners. And then also financial support has been shown to work, and inclusive and non-discriminatory services, as well as involvement of people living with HIV in service provision. So just a word on the changes in our clinics with the external funding cuts. So there was this 2 to 3 month period between February and April of this year, where there were the funding cuts announced and people didn't really know what was going to happen. Fortunately, there was no actual reported stock out of ART at Nigerian Revive sites. Patients did miss their appointments because they heard information in the news media and they misinterpreted it. There was also a lack of case management support, so there were no reminder phone calls. People were hearing all this news, they were not getting their phone calls, and so they didn't come. And now we have 3 monthly drug supply instead of 6 monthly supply, and this means 4 visits a year to the hospital or to the clinic instead of 3, and this is too much for some people to afford. And at the time, some services for key populations was temporarily suspended. So in conclusion, Our ART rates are suboptimal, and challenges that we face must be overcome to ensure the benefits of ART at the population level, which can only be fully realized by halting transmission through effective use of ART. I want to thank Professor Akamu, who's the chair of our National ART Guidelines Committee, and all the Revive site PIs and teams for the wonderful work they're doing. Thank you.
Thanks so much, Kemi. Really extremely valuable perspective from Nigeria there to hear about the particular issues that you and colleagues face. Our fourth speaker is Dr. David Meya. David is a professor and clinician scientist at the College of Health Sciences, Makerere University in Uganda. And he's also a member of the independent DSMB for the Revive trial. And he's going to be providing perspective from Uganda. So I think David's trying to share.
Yeah,
Are you able to share slides?
I'm trying to find them. Oh, can somebody share them? For some reason, I can't see them on my
Okay,
share.
I know Elsa has a copy.
I'll share with you, Doctor, just 1 second.
Thank you. Sorry. Yeah, and so maybe just as the slides get shared, yeah, Graham, thank you for inviting me to just share the perspectives from Uganda. I almost feel like I did not need to speak after Dr. Kemi, because in some ways, I guess this is also the beauty of being the last to speak, because then people have covered a lot of what you would have. Next slide. So yeah, I thought in some ways I would just cover I would cover a little bit from the perspective of what we have done, because I think what Kemi shared was just exactly what's been going on in Uganda, just in terms of the challenges. And so I gambled on the fact that there would have been coverage of some of these issues, and dive sort of straight into what are the possible solutions to some of these challenges. So we've had about, this is just data from UNAIDS suggesting 38,000 new cases for that year, and almost half of those were in this age group of 15 to 24 years. And I think this is important because this is also an age group that certainly presents with specific challenges just around being able to have the discipline to keep taking their drugs. But we also found that there was double the number of infections among women compared to men. And so some of these gender issues obviously play significant roles in how infections are spread, but also just what the epidemiology of the HIV epidemic looks like in Uganda. And what I just highlight on the right is really just the cascade, the number of people living with HIV who knew their status, those who are on treatment, and those who are virologically suppressed. Next slide. So a long time ago, and this is way back in 2009, the questions and the challenges that we're discussing are obviously not new. They've sort of been around since the HIV epidemic. But I think ever since, we started having antiretroviral therapy being available, particularly in the public sector, there've been questions around how best can you develop algorithms that clinicians can use, and particularly if there's a combination of clinical and either virological viral loads or CD4s. And so many years ago we looked at the possibility of developing an algorithm to monitor patients on ART, using adherence, clinical and CD4 cell count criteria. And I know this has obviously been overtaken by the availability of viral load testing now. But certainly, the questions around adherence failure, I think back then we sort of defined this as people interrupting ART for more than 2 days, and we were still doing CD4 testing, with percentages describing thresholds around failure, suddenly showing that when compared to the WHO-based algorithm, there were definitely differences. And so it just sort of speaks to, the fact that I think you can't take away adherence and retention and, virological testing. Those three have to sort of go together. Next slide. And so if one thinks through the HIV cascade, I think the key things are around ensuring easily accessible and routine HIV testing. And I think if that's the beginning of ensuring awareness about HIV, one of the things that we've been able to, I think, to follow through is increase the self-testing in guidelines and provide access to affordable kits. Because I think that's where it starts. In some ways, if an individual, and obviously this needs to be proved by data, but if an individual is able to self-test, I think they, hopefully you assume that they're more likely to, if they start ART, to want to stay on their ART. Expanded ART access, as we said, that's something that continues to happen. And I think one of the major shifts for us was this thinking around moving away from the static clinic-based ART programs to community-based either drug distribution points, the use of home-based care models, community ART groups, and generally in the context of task shifting. I think a previous speaker spoke about prevention and injectable ART, but certainly we still have challenges around, when will we have injectable ART for people who are on regular antiretroviral therapy. And then I think the other aspect has been the community pharmacy models that are increasingly, and I'll just highlight some data from one of our Masters of Internal Medicine students who looked at this question. Next slide. So I'm thinking about key populations, key and priority populations for Uganda, particularly a small study that we did on the islands, which used the intervention that was involving facility and community case managers who were supporting individuals who were initiating ART, sort of within the first 3 months of ART. And the primary outcome for this, quasi-experimental pre-post intervention evaluation was looking at 6-month retention and viral suppression sort of before and after the implementation of the intervention. And it was interesting to note that the adjusted probability of 6-month retention was higher in the intervention phase, and just given that there was a focus on supporting these individuals who were starting ART just for the first 3 months. So an almost 10 percentage point difference. Next slide. And as I highlighted, the community retail pharmacy drug distribution models, under consideration by the Ministry of Health here. And so we had one of our students evaluate, the individuals who were shifted to this particular program where they were receiving their antiretroviral therapy from a privately owned pharmacy, in combination with they were working together with the HIV care implementing partners. So they received refills from 3 to 6 months, and they were only returning to the parent clinic once a year for virus sample blood draw in just as we recommended in our current guidelines. And so these pharmacies receive about $50 per client per visit, and that's being run through the PEPFAR program. And I think one of the key results was that 99% maintained viral suppression, and 4 of every 5 participants were essentially retained in these sites. Next slide, which I think might be my last. Yeah, so really some closing thoughts. I think what I've highlighted are just 2 examples of, you know, what could potentially be done to improve you know, retention and improve adherence to treatment. We know that the cascade of HIV care remains key in identifying who is HIV positive early enough, getting them into care, starting and then maintaining ART. I think there's an increasing need to expand the models of care and actually implement them, find, you know, ways of making those models as cost-effective as possible. And so, as an example from Uganda, community pharmacies are potentially useful just from the data. And programs that engage communities may have better outcomes. And of course, you know, there's always the issue of social stigma that needs to be dealt with. And as most African countries that are, you know, grappling with the numbers of patients with HIV have demonstrated, the numbers at, you know, static facilities have become increasingly huge. And so I think one option that we've demonstrated is obviously thinking about case management models, which might be a useful addition to some of those programs as well. So thank you. I think this was really quick, but I thought these were just some closing thoughts. Thanks.
Thanks so much, David. Really useful input from Uganda, and excellent to hear the perspectives from your country and the issues that are being faced there. So we've got 10 minutes for questions and discussion. And if I can just ask colleagues to raise their hand or to type in the chat if there are questions. I'm going to start off with asking a question to Lynne. Lynne, you mentioned the issue around that some clients raised as a reason why they don't return to clinics, the way that they're treated at the clinics and staff attitudes and behaviors. And I'm just interested if you've been involved in any work or know any work that has attempted to shift and change behaviors and attitudes and make them more supportive of clients who have missed an appointment or disengaged in return, to address that issue and to try and improve that aspect.
Yeah. Not specifically studies, but the National Department had a whole campaign with PEPFAR at one stage called the Welcome Back campaign that was specifically focused at addressing these issues. And we do see quite a lot of variation across facilities. And I think sometimes the CLM data is the most helpful, the community-led monitoring data, which does exit surveys across a lot of facilities every quarter. That gives us a pretty good idea of where we've got those problems, and that those then get identified. I think what's also particularly relevant, but maybe in the Zambian example, is that despite those attitudes, people still intend to return. I think we must also understand that perhaps the bigger challenge is that once you face that judgment or that difficult thing and known that you have to do that, your service delivery model after that becomes more complicated. And so essentially you had a red flag on your head saying, I'm struggling to meet these scheduled appointments. And then we just make it more difficult by making monthly returns, etc., etc.
Okay, thanks. Maybe if I could ask Kemi and David to come in on this issue, just whether this is a problem in your countries and how that's being addressed in terms of healthcare workers' attitudes and behaviors and support for and have lapses in their attendance at clinics. Kemi?
Yes, thank you for the question. Well, we have quite a bit of people who are returning, a good number of people who are returning to care, even within the Revive, among Revive recruits. And there hasn't been any special program, at least for my site, and not at the national level, to necessarily welcome them back. I like the idea of the welcome back program. People at our clinics, people tend to be a little, generally they tend to understand the issues that these patients are facing, but there has been nothing specifically tailored towards them besides the issues of repeated short visits and things like that, which even though they're geared towards helping the patient, they actually might end up being a deterrent, actually.
Thanks, Kemi. And David, is it an issue in Uganda and
So
the patients mentioned?
yeah, so I think we're coming out and transitioning to a new system of HIV care where, formerly you had individuals going to clinics that were specific for HIV care. But, because of funding issues and cuts and so on, the government has sort of transitioned to integrated care now. And I think that's going to present some challenges, particularly with people who, you can imagine if a medical officer in an outpatient clinic is seeing an HIV patient, they're seeing a diabetic, they're seeing somebody with malaria, you can imagine what potentially that will cause if somebody shows up and they're just re-engaging in care and just haven't, seem like they just haven't valued, the care that they've been receiving. I think there's likely to be a bit of a spike in attitudes that might be discouraging to participants or patients who are sort of just returning into care. But, again, I think there's going to have to be a lot of education around the need to just listen to patients and be accommodating. Yeah.
Thanks, David. Just to encourage colleagues to, if you've got questions, to post them in the chat. Also, we'd be interested if anybody's got any experiences to share of interventions or measures that have positively impacted these issues in your clinics. And maybe I can move on to just one of the other questions from the chat that Dr. Yahaya put to Kemi. The site analytics from Nigeria is quite useful. Could it be routine performance monitoring across all Revive study centers, for instance, biannually?
I'm assuming that question is for me.
Yeah, Kemi, yeah.
Okay, great. Yeah, it's something that we could do. Of course, all sites have their own, they have their own performance monitoring. They have their M&E teams that are required to report certain metrics. And the sites, we don't all have the same implementing partner. So it's kind of nice to look at this across different IPs and see what's going on. And even at the national level, they have a mechanism for looking at certain metrics like virologic suppression and so on. But it would be nice because we're just kind of sitting in our different sites and recruiting patients and assuming everything is fine everywhere else. So it's something we can certainly do.
Thanks, Kemi. And then, Catherine, if I could bring you in, there's a question from Max Leitayard, who from the Gates Foundation, who gave a presentation previously at one of our webinars. And Max asked, I would like to follow up in your take on the impact of long-acting PrEP and treatment on compliance and adherence. And maybe, you picked up on this, that might help some people to adhere, but isn't it a kind of double-edged sword that if people have adherence problems and they stop their long-acting, that they could run into trouble in terms of resistance, particularly those on long-acting treatment?
It is, I suppose it is a double-edged sword in that way, but I feel that, if we had, I think part of the issues we have with our program is how single track they are, and we need to be able to offer some choice, and that brings more buy-in. And for people who have disclosure issues, or need their treatment to be discreet, or have shifts and struggle with daily dosing, or to struggle with offering tablets, this would be injectables would be a really good option. And admittedly, at the moment, we're looking at every 2 months, which doesn't help us in terms of reducing the sort of flow through our clinics or anything, but that's the beginning. We're going to be moving on to hopefully 6-month and other regimens further down the line. So like with every change that we've had in our programs, it'll bring some good, but there will also be some people who have a problem. And if we had access to these drugs, we could learn to address the problems as well.
Thanks. I think Max wanted to pick up with you offline on those issues. So we'll put you in contact. And then I'm just going to take 2 more questions. The one somebody had, I think Maxla had her hand up. Or Max, was it you, Max later? No, I'm not hearing anybody. So we'll move on to the last question then. And that's a question posed to Dr. Kemi again. Among negative factors, is stigma caused by health workers? Has the root cause been assessed, and what strategies are put in place to address this? So stigma among healthcare workers, and could that be a factor?
I'm not certain that stigma amongst from healthcare workers has been properly assessed, but I feel like stigma often comes from our inherent biases, and also things that we tend to stigmatize what we don't really understand. And I think one of the things that has been put in place that has helped with this would be involvement of people living with HIV in service delivery. And so if they are part of the team, people work with them and socialize with them, and people who might not be living with the disease, they understand that there's no more us versus them, and that we're all just trying to solve a problem. So I feel like having people living with the disease working as part of the community that's trying to address HIV is something that has been very helpful. And it's difficult to stigmatize somebody who you work with, works very hard, is very responsible, and is just like you. Thank you.
Great, thanks, Kemi. So we're 5 minutes over, and I think we'll wrap up now. Just once again to say a very big thank you to our 4 speakers for excellent talks covering a wide range of issues related to adherence and retention. And then, to everybody involved in the REVIVE trial, all of the investigators, all the colleagues working at the sites, just to highlight that this is, for us as the study leadership, is a critical issue to address, because many of the participants entering the REVIVE trial, not all of them, but many of them have advanced HIV disease because of that they've had struggles with adherence and retention in the past, and we'd really like their involvement in the REVIVE trial to be an opportunity for them to get the support that they need to re-enter care and stay in care in the long term, and that even beyond the time that they're in the REVIVE trial, that they are retained in care and are able to benefit lifelong from antiretroviral therapy. So it should be a focus at all of our sites to support our participants in their journey, in their ARV journey, and addressing issues around adherence and retention. And that's one of the major reasons why we highlighted it today. So thanks everybody for attending, and really great talks, and thanks so much. And we will send out the advert for the next webinar that will happen next month. Thank you.
Thanks, Graham.
Thank you.
Bye-bye.
Bye. Bye. Hi.
Yeah.